In this brief video, The Great VOR Debate, we take a look at the clinical practice guidelines based on years of research compared to more current research findings. And certainly the debate reference here is not about an argument, but just a play on words of looking at this in a couple of different ways. So we'll start again with clinical practice guidelines for unilateral vestibular hypofunction. I've actually given you the reference of this that's produced by the American Physical Therapy Association, and they break down the supportive gaze stabilization exercises into acute and subacute versus chronic. And the recommendations for acute subacute is a frequency of 3 times a day and a total duration of 12 minutes a day at a minimum. For chronic, the frequency increases to 3 to 5 times a day with a minimum of 20 minutes a day, while the overall length of vestibular rehab would be 4 to 6 weeks. Again, you'll see that this is referencing unilateral vestibular hypofunction. They also have clinical practice guidelines for bilateral hypofunction, which is more frequent and a longer duration and an overall longer participation in vestibular rehab. There's no specific parameters defined for VOR times 1 versus when to begin VOR times 2. If you're not familiar with those types, I encourage you to watch the other video on VOR Part 1, Part 2, Part 3, which breaks down the different types of VOR training. But this is a sinusoidal gaze stabilization, and the target distance is 30 centimeters up to 150 and even up to 3 meters. And I encourage you to click on the link for the reference of these clinical practice guidelines. There's also more current research on IVA, or incremental VOR adaptation training. The subjects had a stable vestibular hypofunction. The frequency was once daily. The duration was 15 minutes in one sitting. There have been studies that looked at 3 sets of 5 minutes, but there was no significant change in the actual VOR gain with breaking the 15 minutes up into 3 increments. Their overall length of vestibular rehab, at least 4 weeks, with a recommendation of 4 days per week. Now, these are not sinusoidal. These are ipsilateral head impulses at a minimum of 1.3 hertz to the affected side. Now, the IVA training used technology or instrumented VOR training, and that was wearing a head accelerometer so that the patient reached at least a minimum of 150 degrees per second of peak velocity of head rotation. These were done in 90-second intervals, progressing from a 0.5 gain to a 2.0 gain. So what that means is if I turn my head, if I have a right hypofunction, I would be turning my head to the right 20 degrees, but the target would actually be at 10 degrees. So it would not yet be at that 1.0 gain, or VOR times 1. And these 90-second increments, and then there's a rest, and then it increases by 0.1. There's another 90 seconds, and then 0.1, all the way up to 2.0 gain. And pre and post findings in this research actually showed a change in the VOR gain. We're comparing to traditional sinusoidal head rotation in VOR times 1 and VOR times 2 did not change the gain. So now we'll move on to the newer research in vergence-mediated VOR training. The subjects had a stable vestibular hypofunction. They also had normal convergence. The frequency was once daily. Again, the total duration was 15 minutes in one sitting. The big differential here is that the target was at 15 centimeters. So in clinical practice guidelines, the target, again, is typically 30 centimeters up to 150 centimeters, and maybe with a max up to 3 meters. In the IVA training, the target distance was around 1 meter. So this is a near-range target, and the subjects were performing sinusoidal head movements at 2 hertz. So that's the same as our traditional VOR times 1 sinusoidal training. These were done in 60-second intervals, followed by a 30-second rest. Again, the total time was 15 minutes. I just want to emphasize here, when we look at clinical practice guidelines, it becomes more of a terminology consideration where we think of VOR exercises as VOR adaptation, and adaptation changes the VOR gain or eye-to-head coordination. So what the neuro research is showing is that these traditional VOR times 1, VOR times 2 are not changing the gain, but they're still resulting in subjective and objective improvements. So this is just an overview, a quick overview of comparison of the research out there. I've provided you with the clinical practice guidelines as well as a research article on IVA training and the divergence-mediated VOR. So I hope that you look forward to increased research and novel ways to train the VOR as much as I do.